This week on the BackTable podcast.
Patients who had a female surgeon fared better than those who had a male surgeon. And in fact, the biggest relative difference was driven by mortality differences. And so in the original Ontario-based cohort, there's about a 12% decreased mortality rate at 30 days. We subsequently have looked at this in about a 2.5 million patient Medicare cohort, which shows fairly comparable results. And we've published this past fall a meta-analysis looking at an aggregate of over a dozen studies assessing this question of 30-day mortality for patients undergoing various different surgeries. And the takeaway is about a 5% mortality benefit for patients who have a female surgeon compared to those who have a male surgeon.
Hello, everyone, and welcome to BackTable Urology, your source for all things urology. I'm your host today, Dr. Casey Seideman, and on today's episode of BackTable SWIU, we're going to be talking about surgeon sex and patient outcomes, and we have a very special guest today. I'd like to welcome Dr. Christopher J.D. Wallis, a urologic oncologist at the University of Toronto and Mount Sinai Hospital University Health Network. He obtained his Doctor of Medicine from the University of British Columbia and his Doctor of Philosophy in Clinical Epidemiology and Healthcare Research from the Institute of Health Policy, Management, and Evaluation at the University of Toronto. He completed his clinical residency in urology at the University of Toronto affiliated hospitals and his SUO Oncology Accredited Fellowship at Vanderbilt University Medical Center. So to date, he has authored more than 225 peer-reviewed publications in journals like New England Journal of Medicine, JAMA, and many others. His research focuses on leveraging epidemiologic techniques to understand the interaction between process of care and patient outcomes, with a particular focus on patients with cancer and those undergoing surgery. Recently, his work has focused heavily on understanding the interplay between physician characteristics and patients' operative outcomes. He has authored a series of articles that explored the interplay of surgeon sex and patient outcomes, with some pretty groundbreaking findings. His research has gone viral on the internet, been featured on major news outlets, and he's just a pretty awesome person. So welcome to the show.
Oh, thank you so much for having me. It's an awfully kind introduction.
We try. We wanted to hype you up big time, but we're really thrilled to have you. As you may know, SWIU is partnering with BackTable Urology, and we want to really start covering some of the topics that are near and dear to us, including gender equity. And something that's really popped up over the past couple of years, largely in thanks to your research, has been, does surgeon sex matter, or does it impact patient outcomes? And so, if you don't mind, would you tell us a little bit about the inspiration behind your work?
Yeah, so I think it's a fair and relevant question. I guess it's the elephant in the room, as it were. If you look at me on the screen, I'm not the most obvious, DEI candidate, as people will like the terminology. And so as a white guy operating in these spaces, I think it's really important to think about why we're doing it and what we're trying to achieve. And so, that comes back to how we got here to begin with. And I think there's the proximal and then the more distal sort of explanations. If you think proximally, the answer really is that I was building a study cohort to look at important surgical outcomes, and we built this interesting multidisciplinary cohort. And then one of my friends and collaborators looked at the effect of physician sex in hospitalized medical patients and found something interesting. And I thought it might apply to surgery, and that's when we looked. But if we take a step back, that's more opportunity to realize a simmering question. And so I would say the core experience that shaped my view here dates back to third year med school. And I started my third year clerkship on a surgical rotation. I wanted to be a surgeon, and I knew that. And I was starting on general surgery, and I worried that I would be unprepared to make a good impression necessary to get the letters I needed for residency. And I was lucky to be at a community hospital, which meant that there was no residents around. And so it was me and this really badass female HPB surgeon named Allison Ross. And I remember the first day I met her in the surgeon's lounge, and we went in and we did a hepatic lobectomy. And so I first assisted a hepatic lobectomy like day one of third year med school. And the next morning we went to round on this patient when they were admitted, and the patient was directing all of their questions at me. I was this clueless third-year med student. I could barely find the elevators in the hospital, let alone talk to them about the nuances and implications of their, liver surgery or the technical aspects of what Dr. Ross had just pulled out. And despite that, every question, even when she had answered it, the next one would be directed at me again. And I didn't know what to do about it at the time, and I didn't really do much of anything about it at the time. But it always stuck with me. And so as we've sort of built this repertoire of studies looking at the effect of surgeon sex and gender on patients' experiences and outcomes, that moment has really stuck with me. The idea that, to some degree, our female colleagues are swimming upstream a little bit. They're fighting the currents. And so when we had the opportunity to look at this in a really granular, data-driven way, that experience really fomented the desire to study this in a sort of better, more scientific approach.
So what you're describing in that experience that you had with that hepatobiliary surgeon is an experience that most of us female surgeons live every day. And one of the other things that we hear, and it might be, we overhear or students tell us, is that there is this perception that maybe women aren't great surgeons. And I think that that is something that all of us want to disprove, right? Because why would we put ourselves through all of that training and take care of patients? If that were the case, that would be awful. But there is that little bit of imposter syndrome that maybe lives in all of us, where we know that the people around us are maybe judging us a little bit extra harshly or watching us closely. And there is data that shows that when we have a complication, our colleagues may refer to us less frequently. And so that's why I thought that the data that you've presented and published is so groundbreaking. One of the big things that you look at are patient outcomes. So this is real life data. This is big data. This isn't sort of perceptions or feelings. Can you tell us a little bit about, big picture, what you found when it comes to surgeon sex and patient outcomes?
Yeah, so we started off doing this work using an Ontario-based cohort. So that's Ontario, Canada has the advantage of being a single-payer healthcare system. So we can capture everything that happens for every patient, essentially. And so we first built a cohort of about 25 different surgical procedures across all surgical subspecialties. So urology is represented with things like nephrectomy, prostatectomy, cystectomy, and TURs. We tried to look for bigger operations because we were trying to enrich for patients having bad outcomes. If you're studying procedures where everybody does well and there's no complications, it's really hard to actually find anything meaningful. And so that's the urology subset. And we built a cohort that was about 1.2 million patients. And you're never going to do a randomized trial here, so there's always the question of residual confounding. But for what it's worth, what we could account for was we took patients of the same age, sex, and comorbidity level, undergoing the exact same operation, inside the same hospital, performed by a surgeon that had comparable years of experience and annualized procedure level volumes, who differed based on whether they were a man or a woman. And what we found is that across our primary outcome, which was a combination of death, readmission, or major complication, things in that category being like VTEs, strokes, need for reintubation post-op, MIs, that patients who had a female surgeon fared better than those who had a male surgeon. And in fact, the biggest relative difference was driven by mortality differences. And so in the original Ontario-based cohort, there's about a 12% decreased mortality rate at 30 days. We subsequently have looked at this in about a 2.5 million patient Medicare cohort, which shows fairly comparable results. And we've published this past fall a meta-analysis looking at an aggregate of over a dozen studies assessing this question of 30-day mortality for patients undergoing various different surgeries. And the takeaway is about a 5% mortality benefit for patients who have a female surgeon compared to those who have a male surgeon. There's a bit more nuance to it that we can go in terms of the interaction between patient and physician sex, but across the board, we're seeing better outcomes for patients who have a female surgeon.
So I did want to ask, does the patient sex matter?
Yeah, so it does, and it does in two different ways. So we know that in certain circumstances, men do better and some where women do better. So for example, consistently in cardiac surgery, female patients actually fare worse than male patients. But in many other contexts, undergoing surgery for like hips and knees, for example, mortality is lower for female patients in general. But what I think is more interesting than that is the interaction between patient and physician sex. And so when I quote before that we see a 12%, in our study or 5% in the aggregate studies, mortality benefit for a female surgeon, that's across all procedures and across all patient groups. But when we're thinking about that, there's many different pathways that could come to be. And if it's technical, then it shouldn't matter whether the patient characteristics are the same or different for male and female surgeons. But there's more to it than that, I think. And I think there's things about how women practice. There's things that happen pre and post-op that influence. And so the dynamics between a patient and their physician can influence that. So what we did is we looked at what we call discordance. So when patients and physicians were of different sexes, we call that a discordant pair. And if they're of the same sex, we call it concordant. And what we saw is that patients who were discordant from their physician had worse outcomes than those who were concordant. Now, the trouble is that treats a concordant pair, male patient, male physician, the same as a female patient, female physician. And similarly, discordance would be the same. And the trouble is that those are not exactly comparable. And so what's interesting is that when we look at male patients, there's a small but significant survival benefit for having a female physician. It's in the range of about 10%. But for female patients, the benefit of having a female physician rises to about 30% when you look at mortality. And so that's a statistically significant interaction telling us that the benefit of having a female surgeon is even larger for female patients than it is for male patients. And we don't entirely understand why that is. We can, throw out some hypotheses and a little bit of conjecture, but we're working on getting a better understanding of what's actually driving those differences.
Wow, that's really wild. I wonder if we're going to see an increase in the number of women who are seeking out women surgeons specifically because of this. I do think that pushes the need to create more women surgeons, right? So we need to funnel that pipeline. But I wonder if the people who watch the news or came across your research sort of from the general public, I wonder if this will translate to practice patterns. I was wondering, because you're talking a lot about short-term outcomes, what about long-term? Does it all kind of wash out, or do you still find that, physician sex matters for long-term outcomes for patients?
Yeah, so it's a great question, and it gives me an opportunity to highlight what is, as a bit of a health services research nerd, one of my favorite studies. So your listeners and viewers may know that John Berkmeyer in Michigan, using the Bariatric Collaborative, videotaped surgeons performing bariatric operations and correlated blinded review of their technical skills with patients' short-term outcomes. So at 30 days, the peer-reviewed assessment of a bariatric surgeon strongly correlated with their patients' complication outcomes. What's interesting is that study showed that at 1 year, the adjudicated skill that surgeon had did not correlate with long-term outcomes, things like weight loss, improvement in blood pressure, improvement in diabetes remission. And so there is a rationale to believe that different processes of care exist for short and long-term surgical outcomes, and short-term outcomes may not be indicative of longer-term outcomes. But what's very interesting in our example is that when you move to the physician sex question, the outcomes are remarkably consistent. So we looked at it initially at 30 days, and then this past year we looked at 90-day outcomes and 1-year outcomes. And the odds ratios budge very minimally. And so we see remarkably consistent results over time, suggesting that it's not those same technical characteristics that Berkmeyer and his colleagues were able to capture in their videos that may have short-term but not long-term implications, but rather different aspects of the processes of care. And I think it's important first to emphasize that these differences are important long-term, but even more so, I think from a researcher and academic perspective, it gives us a clue about what maybe is contributing to the differences, because it's, at least to me, speaking to the fact that it's probably not an intraoperative technical difference, but rather other things that these female surgeons are doing.
So, big question that everyone is going to ask after they read your paper or hear about your research is, why do you think this is? What are some of the underlying reasons that we might be seeing physician sex actually kind of show some kind of benefit for women physicians and surgeons?
Yeah. So the skeptical among my colleagues and friends will say that this is all residual confounding and there must be some bias in the data. And the reality is that analytically, I can't tell you that that's impossible. I can say that in different patient cohorts, in different healthcare systems, under different circumstances, we see remarkably consistent results. We just had a meta-analysis accepted that looks at this not just in surgery, but across medicine. And so this is a phenomenon we see in internal medicine, we see it in anesthesia, we see it in the ER. I don't think this is just residual confounding. I don't think this is bias. I think this is real. And so then the question is, what is it? So one hypothesis that I am trying to prove, and is very difficult to prove, is really a bit of an indictment of our surgical culture. And so what I would say is that we can think that if surgery is hostile to women, the only women who will become surgeons are those who are so skilled and so able and so perseverant that they can fight through all the barriers thrown up in their way. And thus we are essentially, through our hostility as a profession to women, selecting only the best. And so you could think of a hypothetical whereby male and female medical students are equally predisposed to be good surgeons. And through our biases, we admit maybe the top 10% of surgically inclined medical students into surgery, but we only admit the top 5% of surgically inclined female medical students. So therefore, the top half of the men are equivalent at the 5th percentile to the whole cohort of women who reach the 5th percentile, and then the bottom half of the men just drag down the averages. That's one theory. So it may be just a selection bias that we're applying. I also think that men and women practice surgery a bit differently. There's things related to risk tolerance and judgment around surgical preoperative and intraoperative decision-making. I think there's things related to communication with our patients, and certainly there's good data that women spend more time listening to their patients. They get more biomedical information, but also more psychosocial information that can help them really appreciate, I think, the patient's perspective and priorities around the time of surgery. But that communication also extends to our teams, working with other healthcare professionals. And so we're looking at a few studies that are going to look at maybe the impact of collaborative care and perioperative consultation and whether that differs between physician sexes and whether that can explain some of it. And I think the reality is that we're going to have a large number of answers. There's not going to be one aha moment where we get the explanation for everything. I think these are multifactorial underpinnings, and it's going to take looking at all of them and appreciating that in different circumstances, different characteristics may be more important. But when I think about it, I think about these data when I try to understand what I can do with it, both in short and long term. And so I would say today, the data allows us to really support and empower women in surgery. We know that attrition in surgery is much higher for women than men. Women are more likely to either leave academia to go to private practice. They're more likely to leave full-time work to go to part-time work, and they're more likely to leave medicine and leave surgery entirely than their male colleagues. And so I think these data really support how important it is to have women in medicine and women in surgery. And then thinking more broadly, this is not about the presence of X and Y chromosomes. This is about behavior and the way people act and things they're doing. And so we're working with anthropologists to understand, the differences in how surgeons behave and how that may contribute to their patients' outcomes, so that this is a teachable moment. We can understand, if in general women are getting better outcomes than men, what are things that female surgeons are maybe doing more than male surgeons such that men can pick up those behaviors. And Tom Verghese, who's a thoracic surgeon in Utah, really highlighted that nicely in commentary around one of our articles that, I think the mature kind of response as a male surgeon to seeing this data is to take it as an opportunity to learn and to grow and to improve the care you give your patients, because that's really the intent of the work, is to improve the care that all patients undergoing surgery receive.
You bring up some really excellent points. And one of the things I kind of want to circle back to is this concept surrounding, attrition of women in the workforce and some of the barriers that they face. So one of the things that you mentioned is that women may spend more time with their patients. And one of the downstream impacts is that they tend to make less RVUs, and they may actually sort of be accused or be known as being less productive as their male colleagues. And productivity is very important, especially in the American system, which hopefully you don't know anything about.
Oh, don't worry. We have our own issues there.
Yeah. So when we talk about stuff like that, I think that they really start to look at women like they're not making enough money for the healthcare system and that they need to kind of work harder or pull their own weight, when in reality, they're probably getting mired in the more sort of care coordination aspects, maybe listening to patients longer. And these are all things that might actually contribute to better outcomes, better patient outcomes. And I noticed that you did some work that also looks about physician sex and healthcare costs, which I thought was really interesting. And are women wasting money in the healthcare system, or are they somehow helping? What's your thoughts on that?
Yeah, so I think there's multiple levels here, and just we'll highlight quickly the data around health systems costs, and then I think there's a lot more to be said here. So what we did is we looked at healthcare costs in terms of physician costs, hospital costs, procedure-related costs, and pharmaceutical costs for patients undergoing surgery. And what we found is that for patients who had a female surgeon, the healthcare system had lower costs from the day they underwent surgery through either 30 days, 90 days, or 1 year after surgery. And so the healthcare system bore less costs, and it was about a 10% difference overall. I think there's levels to this, right? And if we think about why the healthcare system saves money, it goes back to the first outcomes we looked at. If patients are less likely to be readmitted, they're less likely to need reoperations, they're less likely to have an MI or need reintubation and go to an ICU level care, it's clear that that should have downstream cost savings. And so to me, it wasn't too surprising to see that there's cost savings from delivering better care. Like that shouldn't be shocking. But I think the bigger question here is a bit of a quality quantity trade-off. And I think what we have to acknowledge as a profession is that there's different ways to deliver value to our community. So I, in my practice, do a lot of male-facing urology. I do a lot of radical prostatectomy, and I do a lot of robotic partials. And so what that means is that follow-up in my clinic is very fast and very easy. My follow-up appointments are not long because we're doing surveillance imaging post-partial. Oh yeah, your CTs look good, creatinine stable, great. See you next time. PSA is undetectable. Let's talk a little bit about your erections. Let's talk about a little bit about your continence. Okay, let's move on. And so the community needs that. There are patients out there with prostate cancer who need to be seen, and we need to have that high throughput. There's also patients, and I got one referred to me who I saw today. I slipped through, but it's like essentially some form of an OAB / painful bladder syndrome kind of consult. Those take a lot more time. You're not going to have the same throughput. But the reality is that our communities we serve need both services provided. And so the important thing is for our institutions and our departments and our profession to recognize that there is value in me seeing 6 or 8 fast prostate cancer follow-ups in the same time it takes someone else to see one bladder pain patient. And we're both providing value to our communities, and we're doing it in slightly different ways. And I think it's important for us to recognize that while there are many great female urologic oncologists who can bang through the PSA follow-ups as fast as I can, in general, within our profession, female surgeons are more likely to get referred and to be seeing the patients who need a little bit more time. And in spending that time with those patients, they're providing a real value and service to our community. And I think it's important to highlight that patients and referring physicians also expect that of female specialists. So female surgeons and other subspecialists, patients and referring physicians come in expecting that the women in urology and in surgery are going to take more time with any given patient than the men will, and referrals and expectations are triaged accordingly. I know I was talking to one of my general surgery colleagues recently where they went to a blinded centralized referral system where all referrals to the whole center came into one referral number, and they got just allocated out essentially at random as long as it was within the person's scope of care. And the women noticed that they had a massive uptake of the operative referrals and straightforward cases that they were seeing in their practice. And the men were really frustrated because they had a lot of patients that were referred to them who didn't have a straightforward answer. So this was in general surgery. There's a lot of undifferentiated abdominal pain, normal endoscopies, ultrasound normal, can you help? And they were losing out on the straightforward inguinal hernias needing a, lap mesh repair. And so there are ingrained and existing biases that push these patients to female physicians preferentially. And I think it really does female physicians a disservice to not acknowledge that the expectations that our referring physicians and our patients have of them are fundamentally different than the expectations that male physicians and surgeons are held to.
Yeah, 100%. And I think what it says to me too is that the way we measure your productivity and the way we pay you may not be in alignment with what is important in a big picture system like patient outcomes, patient satisfaction, sort of the real nuts and bolts of medicine, why we go into it. And what you're describing is something that a lot of us experience. I'm a pediatric urologist, so I take care of all children, regardless of gender. But I do find that I get a lot more phone calls from outside physicians about those sort of complex voiding dysfunction kids who have all the normal testing and sort of fall under that scope of need a lot of extra time in TLC. And I experience that more than my male partners do. And so those little things really do add up. They're like, it's really a lot of work to manage those patients. So I thank you for recognizing it, because oftentimes women talk about this amongst ourselves behind closed doors because it's a shared experience, but it doesn't feel like a conversation that's happening alongside our male colleagues. So I think that's really important for them to kind of see what we do and to understand. And like this colleague, general surgery cohort who experienced it by blinding their referrals, they get a little taste of what it's like sometimes on the other side, and that's important. So sort of a more, real life question, what kind of pushback or, disbelief have you received in the urologic or greater medical community for this work? Because this is actually pretty controversial. Not only are you coming out here saying that women are not inferior to male surgeons, which I think is a pretty safe thing to say, but you're actually making a claim that women have better outcomes, which I imagine might stir the pot a little bit. So what has the reception been? What has surprised you?
Yeah, so the first paper that we published on this, I think came out, if I remember right, in 2017 or 2018. And I was a resident still at the time. And a program director for a non-urology residency program emailed me and my residency program director at the time after I did an interview with CBC News, which is like our equivalent of MSNBC or something like that. And he said that if I thought men weren't as good as women, that must mean I'm not cut out for surgery and I might as well just drop out of residency. And so that was my experience as a resident. Since that time, there's mixed responses. So I would say in general, most women are fairly receptive. I think one of the interesting things to note is that some of my colleagues in the chair of surgery at my institution is a woman. Carol Swall is a fantastic surgical oncologist. She came up to me after I gave one of these talks and she said, Chris, I've been trying to say some of this stuff for about 20 years and the old guys never listened to me. But for some reason, even though you're only 2 years into practice, they're receptive to hearing it from you. And so,
Bingo.
This is a little, yeah. So this is a little bit off your question and I'll circle back to it, but it's part of the role I see for myself here, which is to leverage the social capital or privilege that comes with being a white dude. Because to be fair to some of my male colleagues, you can't know that you've never experienced. And so you need someone to tell you. And so it's about the openness and receptiveness to hear that. I don't begrudge anyone the fact that they didn't realize that this is the case. If you've never been in a room, if I hadn't been in that room with Dr. Ross, I never would have known at that point in my career the extra burden that she faced relative to, a male partner of hers. So the key isn't to know that it's there from the beginning. The question is, how do you handle it when the data arrives? And so some people like Tom Verghese, as I highlighted before, take this as a senior male surgeon as an opportunity to learn. Introspection, I think, is the ideal outcome here. I've spent a lot of time ruminating on hows and whys and what I can do different in my practice. And we can talk a little bit about how I've translated this data into my own clinical practice, if you like. But other of my colleagues have certainly pushed back and said, they don't believe it, or they think there must be some bias, or, men do the harder cases. And so it must be that the surgeries are more complex, even though you capture non-perforated appendectomy. We know that some non-perforateds are harder than others, or some perforateds, not all perforateds are equal. Some are the really bad perforated appendectomies. So there's always an explanation as to why the case mix must be different. The reality is our study design will never be perfect for that, but the reproducibility of it across so many different care contexts within medicine reassures me that that's not the case. And, we haven't come to blows because I'm not that kind of a person, but we certainly had pretty strong arguments in public and private venues on this topic, because I think this data is threatening to people who grew up and have a formed archetype of what a surgeon looks like, right? If a surgeon is an old white guy in a white coat, hearing that the young female surgeon maybe is getting better outcomes, like that can be threatening. And I think it's not surprising that it's threatening. Just the same way we saw some backlash recently on Twitter when Dr. Jha posted about outcomes from IMG physicians in the US compared to US trained physicians. And we saw some real pushback against the idea that, IMGs would provide as good or better care. And so, I think when you have an ingrained idea of an archetype of what a surgeon looks like, anytime someone challenges that image in your head, it's going to be a bit like unsettling. And it's okay to be unsettled. It's, I think, not okay to put your head in the sand and pretend like all of this doesn't exist.
You say that very well. So tell me, how does this impact your practice, and what of this are you carrying forward in terms of future research on this?
Yeah, so I'll take the clinical part first and then the research. The research can go in a million ways. So clinically, I think there's lessons to be learned here that I can apply even in my robotic prostatectomy population. And the takeaway I take from the concordance analysis is that the same clinical care for a different patient is not necessarily best care. And you have to tailor your care to the population. So it is easy for me, based on my lived experience, to understand the priorities of a mid-30s middle-class guy. I have a fairly decent sense of what their life is like. And the more a patient deviates from that image and that lived experience, the more I have to question whether my assumptions are going to apply to them. And so in the same way that the ENT surgeon has to cancel an opera singer differently than a garbage man for their thyroidectomy, we have to think about the way in which our own lived experiences and who we are as a person affects our ability to relate to our patients. And so, in my research, it's been heavily gender focused, but there's great data showing that racial concordance really improves patient trust in physicians. So particularly for visible minority patients, a visible minority physician, and a lot of the research has been US based and really focused in Black communities, really shows that Black physicians get a lot more trust from their patients than white physicians do. And that translates in a urology context to things like engagement with PSA screening or cardiac risk testing. And I think it overall fits the picture. It sounds a little bit trite to say, but the better as a community, and by that I mean like a profession, we represent the community we're trying to serve, our patients, the better we're going to be able to care for them. And so we need this in terms of gender representation. We need this in terms of, race and ethnicity. We need it in terms of, sexual orientation. We need it in terms of, disability, all sorts of characteristics, because the reality is it comes back to those, male surgeons who didn't know about these barriers that women faced. You can't be expected to know they're there because your lived experience doesn't bring you there. But when presented the data that shows that they are, you need to act on that. And the best we can do to care for our patients who have these experiences is to have a physician workforce that reflects their demographics. Now, if we take it to the research angle, we're working in a variety of ways. We're looking outside of surgery to draw correlates within other aspects of medicine. We're looking at processes of care delivery, and so trying to understand how men and women may practice differently and how that translates to patient outcomes. So I alluded to before, things like preoperative consultation. Does engagement with preoperative anesthesia clinics or cardiologists affect patients' risks of having major medical complications after surgeries, things like that. And then over the last year or so, we've been working really closely with an anthropologist, and she has been following surgeons around in their pre-op clinics to see how they interact with their patients and looking at differences in communication style, in how risk is assessed and risk is communicated, in terms of how prioritization occurs. And so that's been observations of patients and physicians, it's been interviews with surgeons. And we're really trying to triangulate that understanding of how differences in practice translate to outcomes, and how, physician sex is just a surrogate for practice differences and behavioral differences. And if we can, dig down to those behavioral differences, that's actionable. Sex is not actionable. I'm not going to, change my X and Y chromosome content at this point in time, but I can learn new tricks. Like this old dog can learn new tricks. And so I can practice differently. I can practice more like my female colleagues can. And I think, that's the takeaway I want. People ask me, are you trying to put male surgeons out of work? And that's not the goal. The goal here is to all be better and do better and care better for our patients.
Yeah, I think, we think of success as a pizza pie, like there's only so many slices, but that's not at all what success is. There's enough room for all of us here. And, my takeaway from your work is that there is room for women in surgery, in medicine, that we need more of them. We need more diversity in medicine, and I think that will translate to better patient outcomes. So if there's a medical student listening to this podcast who's on the fence about whether they have what it takes to be a surgeon or if they'll be good enough, I hope that this is really encouraging data, because at the end of the day, I think data is a really important form of allyship, because you can kind of hear about perceptions and lived experiences, and it may not kind of take the message all the way home, but it's really hard to argue with data. I mean, it's not that hard, but it's hard. So I really appreciate it. They do. I mean, everyone loves arguing about data, especially in urologic oncology, Chris. But we really appreciate this type of work from the females in urology perspective, because it is a form of allyship. It really is sort of using numbers to show that we are sort of working hard and taking good care of our patients. It validates our experiences, and it sort of maybe puts an end to the age-old question of if women are good urologists. I think that we can finally say, based on your data, that we are.
Yeah, I think it's clear that women are as good or better than men. Certainly, my home life would corroborate that. And I think when I look at this situation, I'm often asked, how do we make things better? And the reality is that I'm not affected by most of the problems. And so I don't have the best answers. But my goal here, and I think what I would encourage other men to do is, use our positions to raise the voices of those who can answer those questions. So I don't have the answer as to how to, fix the system to unbias it against women. But hopefully in some small way, I can, help give some impetus or power to those who have been through the experience and can shed sort of more useful light on how we move forward.
Well, thank you so much. I really appreciate it. I think that's the perfect note to wrap this up on, and can't wait to see you in person sometime.
My pleasure. Hopefully I'll see you at AUA.
Absolutely.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend.
If you have any questions or comments, DM us at _BackTable on Instagram, LinkedIn, or Twitter.
BackTable is hosted by Aditya Bagrodia
and Jose Silva.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles,
Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Chi Ding.
Administrative support provided by Jamila Kennebrew.
Thanks again for listening and see you next week.